Okay, so we'll continue with the just a second with the basilar artery. If you recall from the vertebral artery, we have the pica posterior inferior cerebellar artery, and then both vertebral arteries they unite to form the basilar artery at the medullary pontine angle there. And guess what's going to be the first branch that's going to come off the basilar artery? It is Akef. So this was the posterior inferior. This will be the anterior inferior cerebellar artery. And of course, it's going to ascend on the pons. It was going to give us number of pontine branches. And these two arteries here are the inferior arteries. So what is needed is the superior artery. So this is the superior cerebellar artery. So supplying the cerebellum, you will have three branches: superior cerebellar, ACA, anterior inferior cerebellar, and PICA from the vertebral posterior inferior cerebellar artery. And here they are: PICA, ACA, and the superior cerebellar. And this is PICA from vertebral, ACA superior cerebellar, and you can see this on the angiogram. These are the two vertebral arteries. This is the basilar artery. You can see PICA coming from the vertebral, while the ACA coming from the basilar, and the superior cerebellar arteries before it terminates. Okay, now PICA will supply the inferior. Of course, it's going to be close to the medulla. Will supply the medulla. Will supply the inferior cerebellar peduncle and the inferior surface of the cerebellum. ACA, closer to the pons, is going to supply the pons. It's going to supply the middle cerebellar peduncle, lateral cerebellar surface, and the superior, closer to the midbrain. So it's going to supply the midbrain, superior cerebellar peduncle, and the superior surface of the cerebellum. Now the terminal branch, if you have noticed here, these are the posterior cerebral arteries. Now we have middle cerebral, anterior cerebral coming from the internal carotid artery, and the two terminal branches are the posterior cerebral artery. These are the terminal branches of the basilar artery, okay? Posterior cerebral artery. Now, this is the basilar artery. These are the pontine branches from the basilar artery. This is the superior cerebellar artery, and this is the posterior cerebral artery. Posterior cerebral, between the two is that cranial nerve number. What is this? That separates between the superior cerebellar and the posterior cerebral artery. It's cranial nerve number 3, the oculomotor. Okay. Now, posterior cerebral is going to wind around the midbrain so that it can reach towards the occipital cortex. And you can see it here. This is the posterior cerebral artery going around the midbrain, cerebral peduncles, okay, and it's heading towards the occipital cortex. But before that, of course, it's going to supply the midbrain, and it's going to supply this structure here, the thalamus. Thalamus, 3 branches will go to the thalamus, small, tiny, little perforating branches. So again, angiogram. This is vertebral arteries. They unite to form basilar. Basilar terminal branches are the posterior cerebral arteries. They go around the midbrain and they are destined to go to the occipital cortex. So the posterior cerebral cortex will basically supply the occipital lobe and the inferior medial part of the temporal lobe. Okay, this in red, or I don't know what you call it, red, orange. Okay, so it's going to supply the occipital lobe, inferior medial temporal lobe, and a large portion of the thalamus, right? The lenticular striate branches or branch. It's going to go to the thalamus, and of course, it goes around the midbrain, so it's going to supply the upper part of the brainstem and the midbrain. So signs and symptoms, if you damage or there is an occlusion of the posterior cerebral artery, you're going to have contralateral homonymous hemianopsia, but sparing the macula. Why sparing the macula? Because it has dual blood supply. It also receives blood from the middle cerebral artery, okay? But if there is a damage to the visual area that is not due to occlusion of the posterior cerebral artery, it's like a trauma, a tumor, and so on, there will be no macula sparing. So macula sparing only if you have this hemianopsia due to occlusion of the posterior cerebral artery, because macula has two arteries that will supply it, the middle cerebral and the posterior cerebral. Now, if the two arteries are occluded, something happens to the basilar artery at the end, you will have blindness, okay? And of course, you will have visual agnosia. Visual agnosia, you cannot tell what you're seeing because of the involvement of the association areas 18 and 19, alexia and agraphia, because you don't understand what you see. And memory defect. Memory is the function of the hippocampus. Hippocampus is sitting in the temporal lobe, okay, parahippocampal gyrus. And you will have signs of injury to the thalamus because of the small arteries that will go to the thalamus from the posterior cerebral artery. And this is interesting. Prosopagnosia, basically, it's a disorder where you cannot recognize faces. Not your own face, not your own face. Not your mother's face, not your mother's face. Not your father's face. It's very interesting, and it has nothing to do with the visual impairment or vision or visual cortex. It's due to involvement of a fusiform or gyrus that is present in the temporal lobe. It's very interesting. The pathophysiology of it is not well defined or well known. Look it up, YouTube it, and you will see how interesting this is. But it is a sign of involvement of the fusiform gyrus of the temporal lobe. I want to bring your attention to this to this figure, image again. In yellow, we have the area of the supplied by the middle cerebral artery. And I want you to remember that also the internal capsule, the posterior limb, and the genu and the basal ganglia are supplied by the lateral lenticular striate arteries, right? In blue, we have the area supplied by the anterior cerebral artery. Also, it supplies the basal ganglia, and it supplies the anterior limb of internal capsule. And in whatever this color is, pink, purple, I don't know. That is the area of posterior cerebral artery, which is, occipital cortex, but also it is heavily involved in supplying the thalamus by thalamoperforator or thalamo striate branches. So also this figure sums whenever you have intracranial hemorrhage, it can be due to any of the major arteries, right? Any of the major arteries, anterior cerebral, middle cerebral, posterior cerebral, and their branches. Does not have to be a huge ischemia or a huge infarct. Smaller branches can cause also ischemia and little infarcts. They will leave cavities, lacunes, I think they call them, the pathologists. They will talk above them, the pathologist. So you will have more information from the pathology professors. But, injury to the basal ganglia and internal capsule or ischemia most likely due to lenticulostriate branches, either from the anterior cerebral or middle cerebral. Thalamus, it is the thalamus striate branches from the posterior cerebral artery, and of course, pontine or midbrain, brainstem. In general, these are, the branches of the vertebrobasilar arteries. Okay, if cerebellum, the cerebellar arteries, PK, AK, and superior cerebellar arteries. These are the major arteries that, you will encounter whenever you go through any neuro rotation. Don't worry about tiny little branches. These are the major ones that you will probably ever encounter as uh, general physician or a resident of any other specialty other than neuro. Now, I want you to remember that when in brainstem, and Dr. Yaqeen, I'm sure, spoke about that, brainstem lesions, you will have basically cross-body symptoms and findings because, you have involvement of nuclei and tracts, nuclei ipsilateral, tracts contralateral, and, areas supplied by the internal carotid artery. If there is an ischemia, you will have signs and symptoms of speech impairment, and there will be no signs of cranial nerve injury or involvement. While for vertebro-basilar artery, negative for speech, no speech involvement, and there will be signs and symptoms of cranial nerves injury. Now, all the four arteries, the two internal carotid, the two vertebral with the basilar at the base of the brain, they form circle of Willis. And the idea is basically to connect the posterior circulation with the anterior circulation and the right circulation with the left circulation. Now, connecting the anterior to posterior will be through the posterior communicating artery, which is a branch of internal carotid. It's going to communicate with the posterior cerebral arteries. This is the anterior-posterior connection. While the right and left, it is through the anterior communicating artery, connecting the right and left. The idea of communication is whenever you have, occlusion of one artery, other arteries will try to compensate. So this is the circle of Willis. You're going to see it in the lab, inshallah, and you need to identify the arteries. Now, before we conclude, of course, blood supply to the brain and the meninges and whatever, you have arterial supply, you have venous drainage. For venous drainage, I usually postpone this till we discuss the meninges. Okay, and that's when we talk about venous sinuses. Brain is drained by venous sinuses that are present between the two meningeal layers, and eventually they will all drain to the internal jugular vein in the neck. So we're going to postpone that till we discuss the ventricles and meninges. I have a lecture, I guess, week 7, 8, something like that. But for now, I want also to touch on this blood supply to the dura mater. Dura mater will receive its blood supply from, zillion sources. Like you will have it from internal carotid, from maxillary, you will have it from the vertebral arteries, and so on. The most important is this artery, is actually the middle meningeal artery. Middle meningeal artery is branch of the maxillary, which is branch of the external carotid. So external carotid is gonna terminate within the substances of the parotid gland into two terminal branches, maxillary and the superficial temporal. Okay, from the maxillary we'll have the middle meningeal artery. This is the main artery that will supply the meninges and the dura mater. It's going to ascend up and it's going to enter into the the cranium through the foramen spinosum. And also we have accessory middle meningeal, a smaller branch that will enter through the foramen ovale. But back to the main one, of course, other arteries are there, like, occipital, ascending pharyngeal. But the most important, again, is the middle meningeal artery. You can see it going up here, entering through the foramen spinosum, and it's going to give us anterior branch and a posterior branch. And as you can see, it's going to leave an impression on the skull. These are, impressions caused by the middle meningeal artery, and it is branches, the anterior and posterior. Meninges, as we're going to discuss later, they have two in the skull. They have two layers, one that is firmly adherent to the periosteum of the bone, and the other one, another layer underneath it. So, and the dural venous sinuses that will drain the blood from the brain are actually between these two layers. But anyways, this middle meningeal artery will go up and will divide into branches, and it will supply the dura mater. Now, as you can see, it leaves impression on this parietal or parieto-temporal area of the skull bone, right? And this is a thin plate of bone. So whenever you have, trauma or a strong blow, or, somebody hits you on the side of the skull, these arteries might rupture, and leaving blood. Blood will be oozing between the skull and the dura mater. This is called epidural hematoma. Epi causing accumulation of blood, and hematoma, epidural, outside the dura. Epidural hematoma. And frequently people will ask you about it. They will show you an x-ray of semilunar kind of white structure on the side of the brain. This is indicating basically a hematoma, epidural hematoma. The most common cause of it is the rupture to the middle meningeal artery. Okay, you can see this. These are the impressions left by the middle meningeal artery, the anterior division, the posterior division. So any trauma to the side of the skull there, that will cause bleeding, resulting in epidural hematoma. Now, as I said earlier, venous drainage of the blood eventually will happen through venous sinuses. Venous sinuses, are located between the layers of the dura mater, the two layers of the dura mater, and eventually they will all drain into the internal jugular vein or veins in the neck. But what brings the blood from the brain tissue to these dural venous sinuses, we call them bridging veins. Okay, these bridging veins bringing blood from the brain tissue into the dura and into venous sinuses within the dura. If any trauma to the head, strong trauma to the head, they might rupture these bridging veins, causing bleeding underneath the dura, between the dura and the arachnoid. It's called the subdural, causing subdural hematoma. Okay, so epidural hematoma, damage to the middle cerebral arteries, subdural hematoma between the dura and the arachnoid is due to injury to the bridging veins, bringing blood from the brain tissue to the dural venous sinuses. And sometimes you might have actually bleeding underneath the arachnoid, and mostly that is caused by rupture of congenital arterial aneurysm. This is very dangerous. This is very, life-threatening. Patient will come to you complaining of severe headaches, and MRI or CT scan will show blood in the subarachnoid space, putting pressure on the brain. So the most common cause of epidural hematoma is rupture of middle meningeal artery, okay, due to trauma to the side of the skull. The most common cause of subdural hematoma, rupture of bridging veins, and this can be acute or can be chronic, developing over time depending on the injury. And the commonest cause of subarachnoid hemorrhage is rupture of congenital arterial aneurysm. This is serious, this is life threatening, and it is usually acute. Okay, now as I said, we were gonna defer discussing the venous drainage till we discuss the meninges and the ventricular system. Okay, so we're done. يعطيكم العافية, and I wish you guys the best of luck on your midterm, which is sometime next week or the week after on the 21st, I guess. No worries, you're gonna be fine, inshallah. If you have any questions, you can always email me or drop by, or send me your questions by whatever means you like, and I will be more than happy to answer your questions. This is basically what I think that you guys need to know and is important at this stage. Of course, there will always be more details. My advice to you, especially with these very long blocks, don't dig into details. It is fine if you have the liberty of having too much time. Otherwise, at one point you will be overwhelmed. Just focus on whatever your professor is focusing on, the main points. Don't dig into details. You will be lost. And neuroscience is like painting a picture, one piece here, one piece there, one piece here, and you will not have a, good understanding unless you finish most of the pieces, or bring together all the pieces of the puzzle. So be patient. Eventually, all is going to make sense, inshallah. And as for questions, there will never be direct questions. Okay, what are the functions of the premotor area? What are the functions of... No, it's not going to be like that. It's mostly correlation between blood supply and functional areas. If you have these signs and symptoms, what is the artery that is involved? Or if you have occlusion of this artery, what are the signs and symptoms? Something like that. But they will be very fair and logical questions, inshallah. Okay, so good luck, guys, and I guess we'll see you later, inshallah. Assalamu alaikum.